Invite Dr. Mathew James, consultant ophthalmologist at Medical Trust Hospital, Ernakulam. Dr. Mathew completed his training from All India Institute of Medical Sciences, and he has a keen interest in neuro-ophthalmology, and also the additional factor that his wife is a neurologist. Dr. Mathew is going to speak to us about neuro-ophthalmology evaluation, basics, and beyond. Over to you, Mathew.
Thank you, sir. First of all, I would like to thank KSOS and Thomas, sir, for inviting me for this session. So, straight away, I'll go to the basic examination of neuro-ophthalmology. I'll begin with the visual field examination itself. We are more familiar with automated perimetry and confrontation test. And the confrontation test is actually quite sensitive, and it's a simple test which we can pick up visual field defects. But if a patient, I work in a multi-specialty hospital, so if a patient is on a bedridden patient, how will you actually find out homonymous hemianopia? It might be difficult for you to do a confrontation test in front of him. So a test which I do simple test that I do is that you can use a string, a long string, stretch it out in the front of the patient and ask the patient to touch the center of the string. If he is having a normal field of vision, he will automatically pinch at the center. But in case if he has a right homonymous hemianopia, then he will actually point to the left side of the center, and and vice versa basically. So you can easily pick up a homonymous hemianopia in such cases, which is mostly seen whenever the patient has a stroke. Next thing is, we know that any prechiasmal lesion actually can produce a monocular defect. So is it possible that you can get a monocular defect in a post-chiasmal lesion? The answer is yes, because there is a disparity between the number of fibers in the nasal and the temporal retina. The nasal retina is quite large compared to the temporal retina, and as a result, the corresponding fibers which are passing through the optic tract to the occipital cortex, the corresponding fibers will actually synapse at the posterior part of the occipital cortex, but the fibers which don't have corresponding fibers in the two eyes, those will be actually synapsing. That means the contralateral eyes, nasal retina, will have some fibers which doesn't have a corresponding fiber from the other eye. So those fibers will end in the anteriormost part of the visual cortex, and that is the area with A and B. So if there is a lesion in that particular location, you can get a monocular field defect, a peripheral temporal scotoma actually, in the contralateral eye. Now you might have seen bitemporal hemianopias many a times, the only field that is left behind with the patient is the binasal fields. Both nasal side fields are left behind with the patient. So if the patient has esophoria or exophoria, then he could have a slide phenomenon. So either he could have missing of letters or data in between, or you can have a doubling of data actually. So the word neurological might be read as a patient who has exophoria with bitemporal hemianopia as neurological. So if such patients are found, you can actually help them. You can correct the esophoria or exophoria with a prism and actually reduce the amount of disability the patient has. So these are the things, some basic things about the visual field examination. Now when you are assessing a RAPD, we do the swinging flash test quite frequently, but many a times I feel difficulty with the subtle RAPDs on the ICU if I have to rule out a post-traumatic optic neuropathy after a road traffic accident. So in such cases actually you can use a neutral density filter in front of both the eyes. Then the subtle RAPD will get manifested when you are placing the neutral density filter over the affected eye. So it's a very simple test which you can do in an ICU to pick up post-traumatic RAPDs. Now when you are coming to examination of the eyelids, the first test, an important test that you should do other than the ptosis examination is basically an ice pack test, because you will clinch the diagnosis with that single test. As you can see in this patient, there's a ptosis, myasthenic ptosis on the right eye, and as soon as after the ice pack test, the ptosis has improved a lot. So this one test can help you to diagnose a myasthenia patient, and then you can send for the further treatment of the same. This is a patient with additional feature of Cogan's lid to it actually. Let me see. Can you see? There was a small twitch in the right eye when the patient was lifting up. Now other than this, what else can you look for? You should look for the brow position and the lower lid position. So distinguish between a functional or a blepharospasm case which is actually mimicking a ptosis. So in those cases, if the brow is drooped down, you can take that fact into account and consider that it could be a possibility of a blepharospasm or a functional case. However, in senile ptosis or any third nerve palsies, you can have a frontalis action. And similarly, the lower lid positions can also help in diagnosing, because in Horner's you will get a reverse ptosis. Now, coming to examination of the extraocular movements. The basic things, always check ductions and versions, both of them, because if you check only the ductions, you might miss out paresis. But if you were to look for torsion, actually, you should look for torsion in the supranasal quadrant of the for the limbal vessels, actually. That's because the fixed y-axis, which is not passing through the center of the pupil, it actually passes a little bit laterally, and as a result, the maximum angular excursion of the limbal vessels will be on the supranasal quadrant. So this is especially useful when you have a third nerve palsy, and then you have to find out if the fourth nerve is also involved. So in that cases, you look at the supranasal vessels, ask the patient to do a head tilt to the same side, and then the superior oblique, being the only intort, will, since it is the only intorter left behind, it will intort, and if vessels are intorting, you can easily pick up a fourth nerve is functioning or not. Now, other confusion which can occur with the fourth nerve is basically if the patient has a skew deviation or a fourth nerve palsy. This can also be a similar picture, actually. So in those cases, what you can do is always check the deviation in the lying down position and then in the upright position. Since the skew deviation is actually a graviceptive pathway mediated deviation, if the decrease in deviation is more than 50%, then you can consider the diagnosis of skew deviation. So that can help you differentiate between the two conditions. And then next in extraocular movement assessment, you have to distinguish between restrictive and paralytic, where you can look for a saccadic velocity, the amount of deviation in primary gaze, which has to correspond with the lack of movement in the eye. It is squint, but if it is not corresponding, probably it is a restrictive squint. This is a video of checking the FDT. Okay, we'll skip the video. This is the next thing that you should look in an extraocular movement is whether there is a patient has an aberrant innervation. This was a patient with a complete third nerve palsy in the beginning. Later, when he followed up, he had partially improved, but the ptosis was persisting in the left eye. But you can notice that as soon as the patient is adducting or looking down, the ptosis actually is improving. So these features, if as a neuro-ophthalmologist, if you are able to pick it up, you might be helpful for doing a strabismus surgery in case the patient has to undergo a strabismus. So by just recessing the muscles, you will be able to correct the ptosis also. Whenever you're having a multiple cranial nerve palsy, always check the fifth nerve, because that might be helpful in clinching the diagnosis. Suppose if the fifth nerve, both V1 and V2, both the segments are affected, then the possibility of posterior cavernous syndrome can be kept. But if only the V1 is affected, then it's probably an anterior cavernous syndrome or a superior orbital fissure syndrome. And if the second nerve is affected, then there's no doubt it's a orbital apex syndrome. Now, about light and near reflex, always after checking the light reflex, we don't have the habit of checking the near reflex. We mostly finish the pupil reflex by checking the light reflex, but always check the near reflex, because if sometimes we write light reflex poor, pupils are sluggish, but check the near reflex also. If that is also sluggish, then you can consider that it's an autonomic neuropathy. But if the near reflex is good, then you might be actually in the pathway to diagnose a light near dissociation. So always check the near reflexes also. And whenever you are examining a patient with nystagmus, at least we should write what type of nystagmus it is, what is the direction of fast phase. Now, after writing that diagnosis, actually you can at least diagnose whether it is a peripheral vestibular nystagmus or a central nystagmus, central nystagmus. So, if it is a peripheral nystagmus, what you have to do is just look at the fundus on the disc or any of the vessels and ask the patient to cover and uncover the other eye. You're looking with the ophthalmoscope and you cover and uncover the other eye. So when you're looking through the ophthalmoscope, if the disc is vibrating and suddenly after closing the other eye, the vibration increases, then you can consider that it is probably a vestibular cause. And then you can actually do the provocative test also to confirm which ear is involved. And but two things that you should always keep in mind is that whenever there is a gaze change inducing a change in direction of the nystagmus, it is not peripheral. And whenever there is a purely torsional or a purely vertical nystagmus, always do an imaging, because mostly it will be a central cause. And how can you distinguish a congenital nystagmus from any of these acquired nystagmus? One simple test that you can do is most of our phones have O'Kane slides. you have abs that can give you Ocane strips. So if you have a right beating nystagmus patient, you can give an Ocane strip to the left side. If the nystagmus is increased after giving the Ocane strip, then it is probably an acquired nystagmus. But if the nystagmus either stops or reverses the direction, then it is congenital nystagmus, because congenital nystagmus has the characteristic feature of reversal of Ocane. Now what if a patient has, everything is normal, fundus is normal, disc is normal, everything is normal, but the vision is decreased. We usually send for a VEP or ERG immediately, whatever we think suspect. A simple test, actually what you can do is a photostress test. If the recovery time is more than 50 seconds, probably a photoreceptor damage, and or you can do a Pulfix phenomenon to find out if there is optic neuropathy. Every unusual eye movement is not a nystagmus. You have to think of other causes also. This was a patient with ocular flutter actually. You can see the eyes are having a large saccadic movements, and it is in the horizontal direction. If it is in multiple direction, it is obstaclonus. The other video that you are seeing here is a square wave jerk, small microsaccades you can see. It can be seen normally. This patient didn't have any pathology. He was normal, the square wave this patient. Other one had actually a CKD and associated encephalopathy. That is why he developed the obstaclonus. Thank you, that's all.